professional check-in?
My personal check-in is it's been really fun. My daughter, who is a first-year medical student at the U of A, University of Arizona, is here with 3 of her classmates visiting, and they're all doing research and getting global health exposure. So it's been a blast having them around, and that's on the personal side. On the professional side, this month we have made an important transition for our project in terms of financial accountability. And we have moved to a completely mobile money, cell phone mediated platform for the things we need to pay. And so troubleshooting a completely new financial system process has been interesting, and particularly when you realize we work in communities where the daily income could be between $2 and $10 a day for a family.
Wow. Yeah, for the family. Wow. All right, so let's give the cohort some background on Dr. Mary Adam pre-Kenya.
I'm trained as a pediatrician, and I spent 10 or 15 years doing general pediatric office work. I worked for a large multi-specialty clinic and saw high-risk adolescent females and did a lot of routine adolescent GYN. And then in the merger mania of HMOs and different systems, the group practice I was working for got bought out by a group that went bankrupt, and with 6 weeks notice, I realized I would either be unemployed or have to reconfigure. And I decided that was a good time to try and do some different things, because it was just an interesting opportunity. And at that point, I did a pivot in my career, and I started doing research-related things in adolescent sexuality, teen pregnancy prevention. And that ended up and drew my passions to Africa, where sexually transmitted diseases and HIV were a big factor. I got a Fulbright 10 years ago and came to Kenya and worked with an HIV prevention organization here, and did a small randomized controlled trial of their behavioral change intervention. And that essentially drew us back here full time. So we've lived and worked in Kenya for the last 6.5 years.
6.5 years, yeah. Yeah, so we're going to get into some of the project work and your initiatives, but I think what would be helpful for the crew here to get a little more background is one of the major things you guys had to deal with this year was a healthcare strike, which is kind of unfathomable on our end. But give us kind of the backstory, like what the issues were, and what was it like to be a physician when doctors and nurses are going on strike?
Well, Kenya is a country where 3.5% of our GDP is spent on health. So this is a lower income country where we don't spend a lot on health. And the government health system, the public system, is the only option for about 80% of people in rural areas, and probably 60% of people in urban areas, either because there's no other kind of facility or because they don't have enough money to get into the next tier. So the next tier up financially would be mission hospitals, which is where I'm based. And mission hospitals are trying to figure out how to serve. Our mission at Kajabi Hospital is to serve the poor, to do spiritual ministry in Christ, and to be an excellent training center. And what that meant is that when the government, nurses, and doctors in December went on strike, it meant they put down their tools. It meant they weren't in the emergency room. It meant You couldn't get a cesarean section if you were having a difficult labor at the most cost accessible place. And we were overnight overwhelmed. The doctor's strike went on for 100 days. The nurses settled after about 30 days, so women could get support for a routine delivery. Nurses do the vast majority of primary care in this country, which is immunization, simple acute care. But doctors are the first step up. So if you're going to be like overnight in a hospital, you're going to be looking at a place that has doctors and physician's assistants or nurse practitioner level people. So for 100 days, all those people were completely closed. And that meant our admissions doubled, especially in the newborn nursery, because obstetrics and newborn nursery were the high-risk areas. I had a 1.4 kilo baby travel wrapped in cotton and a blanket 6 hours via public transportation, with her mother arriving at 14 hours of age because she was desperately seeking a place that might be able to save her baby. And because our staff was overwhelmed, we couldn't take any more people. I'm still haunted by the 10-year-old I sent away. We only have 5 ventilator beds at the whole hospital, and not in peds. That's what we share with peds and adult. And I had a child come in with an ascending asymmetric paralysis that looked like Guillain-Barré. And over the previous 3 days, he'd gone from walking and running to laying flat and moving his shoulders like that. And we already had a kid on a ventilator with this same presentation who we'd had for 8 days. But you know, a kid with an acute symptomatology like that is highly likely to live if you can support them by ventilating them till they work through their disease process. And I was like afraid to keep him at Kajabi in the emergency room, because if he quit breathing, you know, I didn't know if somebody would die on the current ventilator, so he'd have a chance. But I couldn't find a bed for him. The only place I knew was a hospital that is high cost. And I said, there's only one bed I know of that's available anywhere. It's at this place. They said, we can't afford it. I said, it's the only hope. And I sent that kid away. And so yeah, it was hard. Our mortality rate in our sick baby nursery quadrupled during that 100 days. I just worked through the stats on it. And whether that's because we couldn't run fast enough with the nurses and doctors we had, or whether how much of it was because we only kept the sickest of the sick. I don't know. The nurses have gone on strike again. They went on a week and a half ago. So we're now already some days into another nationwide nurses strike.
I didn't know that. Yeah.
Is there any questions? What
Shabir was wondering, what does the government do about this?
Well, the physicians and nurses are mad because legitimately so, for several reasons. Number one, they get sick of working at facilities where they don't have the supplies they need to do what they were trained to do. Number two, they were promised a financial pay package 3 years ago, prior to when all health systems were run by the national level. A little over 2 years ago, with the new constitution, healthcare devolved to the states, okay? So we went national level to state level. State entities here are called counties, okay? And so they didn't get what they had been promised. So they have legitimate grievances on 2 levels, and they felt like their issues were not being attended to, and so they stopped working.
Yeah.
Unfortunately, people didn't stop needing care.
Right. So we spent a lot of time even talking about that whole thing. But I'm interested in the group learning more about your maternal newborn community health project. So give us what were some of the problems you were going out to solve with it, and just give us an overview of the project overall.
Well, maternal and infant mortality rates are substantially higher here in Kenya than in the US. So neonatal mortality is 10 times higher.
10 times.
In a country like Kenya, everybody knows somebody who died during childbirth. Frankly, even as health professionals, unless you're an obstetrician, it's hard for you to point to someone you know, even professionally, that's died in childbirth. It's not that it doesn't happen, but it's that kind of rare. And so our project was to try and address what can we do to reduce maternal and newborn mortality. And in a country where 40% of women deliver at home on their own without a skilled birth attendant, that means that you have to address household level decision making. So that's what we do. We are working at multiple levels in the health system to help change people's household level decision making process around choices for where they deliver, choices about understanding in terms of what makes you sick or what makes you healthy during pregnancy. When would a newborn or young baby need medical care versus when are they okay to treat at home? How do you identify danger signs? And that identification of danger signs means household level decision makers would now have information to make better choices about their health.
So before you guys were doing this initiative, how were those problems trying to be addressed?
To the level that people had correct health information and access to services, they would do what they could in terms of formal medical care. But a lot of people, just like a lot of people in the US, I'm going to do what my grandma or my mother tells me to do and what's really a good thing. And if your understanding of what makes you healthy or sick is culturally determined, then you will have some different impressions about what to do. Let me give you an example. If you grew up in a community where you thought all babies who had a cord around their neck were just going to die, why would you go to a health center? Because you'd never seen anybody, as a health professional, reduce a nuchal cord and have that baby come out alive. You just assume that was normal.
Yeah.
So changing understanding around those things, as well as other health promotion and prevention things, matter.
Yeah.
If you lived in a community where you were afraid to dig holes because that was the equivalent of a suicide wish, it's really hard to get people to dig and use a pit latrine.
Yeah. So one of the things that we've been talking about with projects is early on, try to come up with what the measures of success are going to be, so you have something to shoot for in that regard. So when you took this on, how would you measure whether this initiative was going to be successful?
Well, I think one of the things we did right, Andy, is we started looking at measuring success in terms of building relationships. No matter what kind of teacher or trainer or background you are, until you have the trust of the people that you're teaching, it's not going to matter. And the more important those decisions are to their family, the more important it is to be trusted. So the first measure of success was, have we grown in a way that deserves and merits the trust and respect of the household people we're trying to work with? Over time, who we needed to build relationships with changed. I mean, it's now run the scope of, the National Technical Work Group on Operational Research in Community Health. That's one level of building relationships, all the way down to the family that lives in a mud and stick house in an area where they got displaced in the last election violence, and now they're essentially squatters. Building trusting relationships along that whole spectrum is essential. That's maybe the most important measure of success. But there are also a whole range of public health metrics. Did we increase the total number of women going for prenatal care? Did the number of women in the community where we were working increase in their actual number of deliveries at a health facility? And that requires looking at data that's meaningful. And we published some of our our results during those earlier years in PLOS One, looking at what is the effectiveness of a community health worker program in rural Kenya.
Thank you. That kind of question from me.
Sure.
Is the government a stakeholder in this project?
Is who? The
The
government?
government.
Yeah. So let's talk about stakeholders. Shabir was asking, would the government be a stakeholder? And in what ways were they a force for good to help? In what way were they maybe an obstacle? Because stakeholders can be either, right?
Well, the government is very much a stakeholder in terms of healthcare. And so one of the things that we've done is work within the government curriculum to say, how can we help build your curriculum to work better in the places that you're doing? That's part of our research and development area. At the local level, you have to work with the local Ministry of Health. Okay, so in the US, we'd call that, you got to work with your local public health department and your local providers. It's amazing to me how often a nurse positioned at a local health center doing primary care is there for 1 year or 2 years, may or may not speak the local vernacular, and then gets moved out. So doing things to help build trusting relationships with the community and that local nurse in their own local facility is a big deal. One of the things we've done particularly this year is there's been development of some new facilities. Kenya is working and making progress at getting healthcare facilities closer to people. So what you and I would call an outpatient clinic. Well, if the neighborhood doesn't know that the health center is open and that there's a nurse at it and that that's a person you can trust, nobody will go there.
Yeah. That makes
So
sense.
building a community health volunteer network around that new facility has been a very important part of what we did back in May.
And your model is not for you and your team to go out and do all of the work. It's to train people in the local area, right? And so they're
Exactly.
hearing from someone who knows literally the culture of that particular the village or whatever. So who are some stakeholders that were not as obvious maybe up front, but turned out to be really critical, that if you didn't win them over, they were obstacles, but they could really help you once you did identify and manage it?
The local chief was a really big stakeholder. So we translate that into saying the mayor. So the mayor of the village really mattered. They were like the gatekeeper of, do outsiders get in or not? And in the same way you couldn't start a business without a business permit, you shouldn't start in a health education class for volunteers without going through the gatekeeper. So that was a big surprise to me because I'm not used to people in that type of a position having so much power to saying you should let them in or not.
Right.
Another thing, and this was really in the last 2 weeks, this was another example of people I didn't expect who could totally help. Over the last 2 weeks, one of our teams with a group of 30 community health volunteers did a household health indicators survey, visiting 1,000 households in an area where we were working. So what they did before they started is they delivered a letter to the pastors of every church in that region. So every church, and that means you have to hand deliver it. And the letter was read aloud in church on Sunday, and they said, you will be visited by people from our general community that are community health workers, and they're going to be coming and asking you questions. It's so we can understand our health problems. I tell you, a couple of years ago, we realized how helpful that was because before we did it, you'd go knock on doors and people would look at you like, what are you selling?
Right.
Okay. Or are you some strange political committee?
Right.
And it made all the difference to do that. Again, all these community group stakeholders really play a big role when you're working at the grassroots level.
Questions?
You know, one of the things we talked about with projects is that we often have more deliverables than what we realize. So more things that have to be created. So we have to think about stakeholders. We have to, measure success, but we also have more deliverables maybe than what we realize. So for your project, your initiative, what are some examples of some of the deliverables that had to be created in order for your project to be successful?
Let me share a couple from the last 3 weeks because we've been trying to work with this mobile money platform for increased financial accountability. We realized we had to make a bunch of forms, and the forms needed to have a wider space so people, when they printed their names and their phone numbers, because the money gets sent to their phone number, okay? And we had to have a time lag in order to check and make sure they were properly registered on, it's kind of like Venmo. Is that what it's called? One of those, where you can share money things?
Yeah, okay.
So that was one thing we had to create in the last couple of weeks, because when you're out in the field, you take a picture of it and you can send it on WhatsApp to the guy at the bank computer who's logging in, who gets paid their bus fare reimbursement today. Another deliverable we've had to deal with is changing training because the needs of the health system in this region are different. So the government says you should have a maternal newborn class and it should be 6 days in a row. Well, that really wasn't working for our local farmers, because by the time if you hit it and this was when it rained, you needed to be out pulling weeds. You couldn't just leave for 6 days. So we had to adapt that deliverable to do a class about once a month. And then these people who are subsistence farmers were able to get their crop in the field, and they could take 1 day out and they could make it up, but they couldn't take out a whole bunch of days all at once. So those are different kinds of deliverables. One is a financial accountability deliverable we had to do in order to maintain compliance for our donors. And the other is a course change or deliverable related to working in the context that we have.
Yeah. So we haven't really covered it in class yet, but it's the next time we get together, it's talking about risks. So identifying the risks, what could go wrong, and coming up with plans to mitigate it. So how did you guys deal with the whole risk side? And what would be some examples of things you anticipated up front? And how did you go about managing those risks?
Well, I'll give you one of my risk management strategies for today. I'm talking to you from my dinner table in my home, and I have an internet provider like most of you do at home. But the internet has been unstable enough that I have the internet option number 2 as a mobile modem on a completely different carrier, and internet option number 3 where I could tether to my mobile phone, which is internet option number 3. And I can tell you that just this week at Kajabi, I had to use both of my alternate options because things weren't working well at all.
Yeah.
So how do you deal with when your communication systems don't work? That's one kind of, you need a risk management. We are working, part of our project work takes place in a part of Kenya that's near Somalia. So we're working in a very high need area out there. Risk management there has to include everything from if we have people in the field and there's a terrorist attack, how do we get them out? Who's in charge of what kind of transportation? But simpler things are common. We have a pickup truck that we go to sites in. It's got a 4-wheel drive. What do you do when you have a breakdown? And so those are all risk management things. And then here's one that you're just not used to, okay? We can have a scheduled training activity and we're ready to go. And the night before, the lead nurse who'd be doing the training gets a phone call from the chairman of that community health volunteer group who says, tomorrow there's going to be a funeral. And what happens in these smaller communities is that you would all drop everything you were doing and come together and support and be with the family. So on 12 hours notice, a whole day's worth of work is completely altered. And the way we manage that risk is we just reschedule, because the respect that the community requires, both from us and from those volunteers, is that they're involved in the lives and the families of those people near them. And when they're needed like that, then it doesn't matter, what your output was supposed to be. You need to be with them the way they need you to be with them. Yeah. So those are just 3 radically different kinds of risk in terms of getting the project delivered on time that we deal with.
The electrical infrastructure is getting better in Kenya, right? But you're still regularly visiting villages with no power. Is that true?
That is totally true, but it's getting better. Yeah. So the facility that we were working with to develop a community health volunteer network last month, they'd put up the building, but they had no power access to it. Okay, so it was about 45 minutes from Kajabi Hospital. So you could see power lines, like we had a drive to get to them. So you go off-road and it feels like you're going off-road in the West, and so they were about 4 kilometers from the power line, but they didn't know when the power line would actually come to them. So at that facility, daylight was your option. There's a facility that we've worked with their community unit, and they're struggling with water, okay? So they don't have a regular water supply. The city water is irregular and unreliable. So it makes service delivery at the facility difficult. It also makes household hand washing and cleanliness difficult when you have to haul water.
I have a question. Can Ms. Mary talk about her project team? Like, who are the team members? What kind of people are there?
Right.
What are their roles?
Right. How would you describe your project team? Number of people, type of roles, and maybe even their backgrounds.
So I currently have 6 people on my team. 3 are nurses, okay? 2 are interns, meaning they have a diploma, like a junior college or a bachelor's degree in community health and development, but they've never had a job. So they don't know so they're just starting. So part of what we're doing is growing them up. And I have a project manager who's managing day-to-day things, who's been with us 7 weeks. So we're just in that transition time to having somebody else looking at all the budget lines and doing all the day-to-day scheduling in addition to myself. We have another physician who works with me, and that person works 2 days a week, and we're doing health systems research, looking at women's delivery decisions. So that's our team, and we do our best to stretch and cover a lot of territory.
Yeah.
Yeah.
For Dr. Adam, there are 2. One, once the trust is established, do you notice differences in adherence patterns there compared to the U.S.? That's number 1. And number 2, is there screening for postpartum depression and how that may influence decision-making?
Yeah. Were you able to hear that, Mary?
I couldn't hear that. I need you to repeat it.
Yeah. Once trust is developed, does adherence increase similar to what you might see here? I mean, once that trust hits, and is there treatment for postpartum depression over there?
Screening for postpartum depression. Let me go to the first step, which is once trust is developed. I'll tell you a story. We trained a community health unit of volunteers, and they were attached to a health center where there was a nurse who was doing deliveries. Prior to the training, they hadn't met each other, but they started working together and they formed a really good team. People from that community were increasingly getting immunizations for their children, going for antenatal care, and delivering at a facility. After 2 years, that nurse went on maternity leave, and another nurse came in. That nurse had a husband who was running a small pharmacy, and all of the medicines from the clinic started showing up in the private pharmacy. And the new nurse instituted fees which were not part of the government system. Well, trust immediately broke down with this person, but it took our community health volunteers a while before they were courageous enough to go and approach the health system higher ups, because these are people with low status and low power, before they could say, look, this is what's happening and it's not right. So trust is huge. All over Kenya right now, people are suspicious of the government health system because we've had so many strikes. If I go, will they be there? Today I had a discussion with a dentist, and she said, dentists are not on strike, but people are, once they hear some of the government system is striking, she goes, I've only been seeing 4 patients a day because people think we're on strike too, but we're not. So this trust factor is a huge issue.
Yeah.
There is insufficient screening for postpartum depression because while up to 95% of women will be seen at least once for prenatal care, the percentage of women who get any kind of postnatal care is very low. So maybe only 40% of women get any postnatal follow-up. So you're not getting a lot of screening for depression. I can sadly say that's true.
Yeah. Any other questions? Yeah.
So when we talk about assumptions, we talk about those sort of unwritten rules.
Yeah.
What has been the most surprising cultural unwritten rule that has been a challenge?
Right. So Mary's asking, we talked about assumptions are sometimes these unwritten rules that are not obvious. So certainly coming from Tucson into East Africa, you had all kinds of learning cultural there. Any other assumptions that you feel like were either made well or that you had to learn that they were unwritten rules in order to be effective?
The style of communication between me and our Kenyan nurses was one of the things that surprised me. Loud talking means you're mad in this cultural context, particularly with the ethnic group that is predominant in my area. And so when I get excited, I talk loud and I talk fast, and I needed to change that. But cultural assumptions go both ways, and part of them are about health questions. We've been working in Maasai communities, which are pastoralists. And in the community we were in this year, one of the myths we learned about is that the traditional birth wife determines if you're not supposed to have sex with your pregnant wife after about the 4th month. And if you do, the concern is that you'll get dirt on the baby. And as best as we can tell, dirt is interpreted as a heavy vernix kind of covering that is, from a medical standpoint, normal. But if the baby, by the traditional birth wife, has this on it and there's dirt, then the man is fined because he is not taking proper protective care of the unborn baby. And the fine is he has to pay a whole cow to the midwife.
A cow.
And I can tell you this is, while we might chuckle, it is not a laughing matter because we had both men and women across the age spectrum, and the men were like, oh yeah, you gotta, you have to follow the rules in order to, have things go well for the baby. And there's a whole range of assumptions people have related to those kinds of health and disease aspects that are cultural.
Yeah. Huh.
Is there any traditional medicine?
Traditional?
Medicine.
Yeah. When you say traditional, you mean non-traditional? So, yeah. So I remember from previous conversations that there would still be a lot of medicine or medical care being delivered by witch doctors, let's say, or not other non-traditional. So is that similar? Is it changing? How's that affect what you guys do?
Well, first of all, let me compare it to the US, where we have a tremendous number of people seeking alternative medicine. Okay, if you're physicians, you can just say who this last week that you saw had used what you would call a alternate medical source. So when we think of it like that, that's an area where the US and Kenya are very much alike. We often don't understand the disease progression or process in the alternative system, okay? And so, yeah, a lot of people here get treatment from alternate kinds of providers. They just don't look as much like the special spa with the, hot stone treatment and the funny enemas. I mean, if we're talking to medical people, we think some of those things are unusual. But herbs, okay, you just pay more for them in the US because they're bottled at those, vitamin medicine stores. All kinds of herbs and other alternate treatments are used here, and they're given by practitioners who have some local respect or understanding. Yeah. But here there's advertisements, pieces of paper slapped on telephone and electric poles that they can help you with any variety of things. So the alternate providers can help you with your business problems, they can help you find lost love. There you go. But I'm not sure that's so different.
We fancy ourselves more sophisticated, don't we?
Yes. What is different is in the US, you would rarely find somebody who said, I don't want a skilled professional to attend my delivery. Okay? They might not want to deliver in a hospital, but it's not that they want to deliver at home on their own.
Yeah.
Why didn't her folks go on strike?
Yeah. Duncan was asking, why is it that your folks did not go on strike?
Well, Kajabi is a mission hospital. Our whole mission and vision is to care for those who are sick. It is against our ethical principles. We do not view our relationship with patients as a contract. We view it as a covenant. And when you have a covenantal relationship, it's more than just business. When medicine is reduced to a business commodity, you've got a contractual relationship only. And so if you have a sacred trust of patients, you have a different level of responsibility. That said, we in the US also have a different functioning level of system. I am not at all opposed to collective action by physicians and have written on that in the past. But I do feel that not to provide life-saving care is difficult. The most difficult for the patients. But that said, I'm living in a country where there seems life is cheap. If you watch the way people drive and the unregulated kinds of, or should I say regulated but unenforced traffic issues, the number of people who die in road traffic accidents that are completely preventable here is appalling. So we weren't employees of the government. We had a different view and mission, and as sympathetic as I am with the healthcare workers, at some point you have to decide who you are and what you're really supposed to do.
So, Dr. Adams, what is your primary source of funding?
What's your primary source of funding?
Everything for our project is funded by donors, people who say that's worth investing in. If you want to know more about that, you can check our website, Equipping Africa, and you can check the website for Kajabi Hospital. Kajabi Hospital's financial model for its inpatient care includes some money funded from patient fees, but we also raise money to be able to support the level of care that we do. So all the docs there help do fundraising. But every single dollar that's spent for salaries for the nurses on our team, for gas in the truck so we can get there, for bus fare, matatu fare reimbursement for community health volunteers for a cup of tea when they come. That's all raised by individuals and small family foundations that think this is worth investing in.
Is that primarily North America donors?
We have European and North American donors.
Yeah.
Yeah. So, those kind of companies with corruption in the government, how do they cut through red tape if they want something approved? What are the steps? How do they fight that?
Right. Yeah, Samina's wondering that with corruption that is in the government, how do you cut through the red tape if you need something done? What are some examples?
The strength of your relationships makes getting through certain kinds of red tape easier. Because we've had a trusted relationship, particularly in the 4 counties, you can sort of think states, that we're emphasizing our work in, we can get to the decision makers much more easily. That's been a big change in stakeholder alignment and management over the last 7 years. Red tape is usually a barrier, but when they know you're there to help, they want to try and make it happen. So if I knock on the door of the district minister of health's office, who's a guy who's about 3 years past his internship and he's trying to run the whole public health side for that area, he picks up my call, he opens the door. And so I think it's that strength of relationships. If you've given value and you've done it repeatedly and you've developed a platform that says, I can trust them to follow through, it makes a huge difference. Which doesn't make it easy, doesn't mean you don't have to call 6 times, doesn't mean you don't have to track the follow through all the way by yourself. It just means there's a chance instead of no chance.
Right.
A person have a question for Dr. Adams. Projects require a lot of commitments, and she's left a pretty good life to sunrise around move to Kenya. What makes her commit? What makes her take? What
Right.
drives her forward?
Yeah. So the track of selling it all out of Tucson and going over an ocean to a culture that's quite different is not necessarily a well-trodden path there. So what is it that makes you tick, that got you and your hubby to pack the bags?
When I was a medical student, my husband and I went and worked in Liberia back in 1981. And in that country at that time, there were only 3 pediatricians in the whole country. And that's when I said, where's their need? And it took a long time to be able to invest in a place where there's real need. But the need here is real, and that means the chance to impact for good is huge. So I think the opportunity to give to others has been a real draw. Day to day, the hard parts of putting that together, when the days when the electricity doesn't work and, you need 3 backups for your internet and you feel far from family you love, you need something more than just the joy of serving others. And for me, that comes because I look at, as a Christian, I have to say, wow, what did Christ do for me? How could I not respond in the way if I say I'm a follower of his?
Yeah, there's so many daily comforts, but when you moved into the place you live now, what wasn't clear was there was a disco across the way that lit up about 10 o'clock at night. Right? So this has affected so many different aspects of your life.
It's a really big change. And culturally, you know, I'm never going to fit in. I don't get the jokes.
I don't get them
There's
either.
a certain part about being foreign. That's hard, but I tell you, the joys of being able to work with the bright young minds of Kenya, the ability to help grow Kenyans to ask the good questions and to build the answers they need for their context. I mean, that's just a joy. Monday, I'll be going to the Dandora slum area. Dandora is the giant city dump, and there's this whole 5-phase informal settlement built on the dump site, okay? And I'm going there with Jackie Arati, who's my doctoral student, and we're looking at how to build better healthcare decision-making in women in that area around maternal and neonatal stuff. I mean, where else would you get to do stuff like that in the world?
Yeah.
And so the opportunities here make the challenges easier to deal with.
Yeah. You know, we really didn't talk about your husband, but he's a physician as well. What's Rod doing?
Rod's on faculty at the Aga Khan University Medical School here in Nairobi. And it's kind of funny because he's working at the high end of the system and I'm working at the low end of the system. He's training specialist physicians in pathology and internal medicine and infectious disease. I'm working with community health volunteers at their local level.
Sure.
But we're building capacity in Kenya's health system to meet the challenges that it needs to day to day, and we find that very rewarding.
And when Rod showed up, he was what, second or third infectious disease doctor in the country or something like that?
Yeah, and now he's in the process of reproducing himself.
Mm-hmm. Yeah.
Here.
Yeah.
Where people, you know, if you go away to somewhere else for training, it's almost always nicer on almost every level, and it's much harder to go back.
Yeah.
So if you train here, then you're more likely to stay.
I'm curious about any safety concerns going into being able to travel around neighborhoods and these slums.
Yeah, Mari was asking about safety concerns, because like going to a slum would seem like there may be some safety concerns, and you've spent a fair amount of time in northern. In fact, I think you've gone into Somalia. Have you? Have some of your meetings been up there?
No, I still aspire to that, but Garissa, we are working in places that are the Kenya and Somalia are borders, and it's a little like the Mexico-U.S. border. There's not a wall everywhere yet.
Yeah.
And so the Garissa trips I take are areas that are out in that region. And we're in the process of developing a memorandum of understanding with Garissa University. They've asked us to come in and do some community health training to undergrads. We're developing a supervision course for mid-level managers, how to help them. You know, the real implementers in your health system are not the high level, it's this lower level. And we're going to help them learn how to work better with community health volunteers and community health extension workers. So that stuff is all in process. And Garissa is our highest need area. It's about a 6.5-hour trip to get out there.
But from a
So when you go, you stay.
From a personal safety perspective, would you say you generally feel very safe? You just get used to the risk. I mean, how do you personally deal with that?
Well, yeah, I think you decide where you want to be. I mean, this last week, London was a bad place to be, if I recall. Okay.
Mm-hmm.
every part of living has a certain level of risk. Road traffic accidents are the biggest risk I have in Kenya, in spite of the fact that we have active cholera. And I'll tell you, really treating real cholera is really scary. It sounded scary in the books. It was scarier face to face. But we're always assessing and dealing with our risk. And sometimes the greatest opportunity in finances, you'd say the greatest opportunity is going to come with the greatest risk.
Right.
I don't think that's different. And so if you want great opportunities, you've got to have a higher level of risk tolerance.
Yeah.
But honestly, the most uncomfortable part of going out to Garissa was my bus ride back, where I had 3 back-to-back Rambo movies. 6.5 hours of Rambo on the bus was more than my personal preference.
Well, if anyone here in the cohort would like to contact you, are you okay if I give them your Gmail address?
That'd be great, Andy. Much appreciated.
Well, Mary, thank you very much. She can hear us from Kenya. How about that?